So what we've got here is, if you see over here, the left wrist has been prepared here, and we're going to get going, okay? And we'll show you kind of the techniques, or I'm sure Jeff's trying to talk to you a little bit about that. What I've been doing is usually doing a front wall stick, and Jeff will show you sort of the double wall stick here, and we'll kind of get going here. So I'm really just feeling the pulse here, and it's got a nice good pulse here. And you doing okay there? Okay, good.
So John, you should say the pulse is barely discernible.
Right, right. Theatrics, right? A little more burning medicine here. Okay. You just kind of raise a little wheel there. Good.
So we tend to make a wheel and then just kind of massage it a little bit and get the volume to go away so it doesn't get in the way of you hitting the artery.
All right. Get my gloves on appropriately. Okay, so this is a Cook needle. It's a pediatric sort of Cook access needle, as you see here. And your institution probably has them. If you're not routinely using it, you don't. So this is one way of doing it, and this is sort of the most conventionally what you're used to doing with the Seldinger approach from the groin.
So John, this is Mauricio here from.
Yeah.
So the other brand, so that's a Cook needle. It's nice, and then the other brand that they can find is the Argon Needle. It has a 2.5 centimeter length. Or 1 inch. They come in 2 inch for micropuncture or 1 inch. It's much better to use a shorter one because you can see the pulsatile flow more easily. And you don't really need a pulsatile, the long one, because it's a little bit more difficult to manipulate. You are in a very small vessel with a lumen of 2 millimeters. So the shorter needle is a lot easier to control.
Yeah, the long micropuncture is about yay long, and the resistance just to backflow means it just drips.
Hurting you?
It doesn't really squirt.
Okay, sorry. All right. So I didn't hit it right off the bat here, so maybe I should have said what you said, Jeff. All right. All right. And he's still a little bit uncomfortable there, so we're going to numb him up a little bit more.
So the other technique we'll talk about mainly tomorrow is knowing sonocyte. So sonocyte, so ultrasound-guided access is a must. It's not that you necessarily need to use it all the time, and most of us, a couple of us do use it all the time. I don't, but Steve Goldberg, who unfortunately couldn't be at this course, he really loves sonocyte, and he teaches fellows all the time, and it really works well for him. And it makes a lot of sense.
So there you have the pulsative flow in the needle, and now I think that John is going to introduce the wire. So one important thing when you are getting access with the needle is that you don't use a hydrophilic or plastic jacketed wire to get access, because you can strip it. You can strip the coating off. When Jeff shows his technique with the angiocath, you can use the plastic jacketed wire. Right, Jeff?
Yep.
Okay, so this is a we call a slender sheath here. A little pressure there, and that should do it. Can you guys give him a little bit of sedation, please? Okay, thank you.
So if they're having pain at the access site, after we've got access, even with the wire, I'll typically put another cc of lidocaine kind of underneath the artery, because we tend to numb them up superficially. And if they're having pain when you're trying to push the sheath in, again, do that, and then they won't feel anything.
Okay, so this is a little bit of verapamil here. It's 2.5 milligrams of verapamil. It's in the syringe here, and we're going to dilute it with blood, because the pH of the verapamil tends to be very toxic or irritating when you inject it. I usually tell the folks, your arm's going to feel a little warm here, and it'll pass in just a moment. Okay.
So one thing about the slender sheath is the color coding. You know that all the 5' sheath are gray. The hub is gray, and the 6' sheath, the hub is green. Here I have a combination, so it means that the outer diameter is of a 5 French, but the inner diameter allows the passage of a 6 French diameter. So that's a color coding for the.
So you see that the little hub is green, and then the next part down is gray. So that would be a 5/6 slender.
Right. And here's a JR4 catheter with a Rosen wire, and then we're going to insert that in. And what I've lately been doing is, I think folks kind of advance it. We just go slow with the wire. You don't want to really ramrod this in until you get beyond the elbow. And Laura, who's here with me, is helping with this, and it's going smoothly.
So John's comfortable with Laura doing that because he knows Laura. I'm not. I want to move the wire myself. I mean, not Laura, but I like to move the wire myself because that feel thing is really important to me.
Okay. there we go. See, now you can see there's the wire, and it's probably down in the descending there. So one of the things is that we've learned is to stop fluoroing when we're advancing the catheters once the wire's in, and that cuts down on the radiation a bit. And so sort of you can kind of get a sense about where you are. Obviously, in this case, we are likely down the descending aorta, as you can see here. So we're going to pull back.
So we'll typically go in with a R4 or R3.5. And then John's going to be able to crank that clockwise and move the tip over there, and now the tip's almost there. There we go.
Almost.
And he's going to be able to go down. We need to pull back just a little bit. And there we go. Now, one of the issues...
Sometimes you can have the patient take a deep breath.
Yeah, that's what I'm going to do
lower
next.
the diaphragm.
Mr. D, would you take a deep breath in there for me?
So going up on the left side,
Yeah, go ahead and breathe.
it's nearly always easy just to rotate that over and go down. The Rosenwire is a little bit stiff,
Yeah.
so sometimes it's a bit of an issue.
In some cases, what we'll do is just get a glide wire to negotiate
go.
this.
Just needs to rotate a little higher.
There you
There
go.
you go.
Yeah,
Almost.
I think. This is, again, atherosclerosis does this.
There we go.
Yeah. Okay, take a deep breath in right there. Nope. Go ahead and breathe. Then we have a glide.
So is that the Rosenwire you're using,
Yeah,
John?
this is the using
Have
Rosenwire.
you tried, so Merit makes a baby J that is softer and it's not hydrophilic coated. I don't know if the hydrophilic coating is something that...
Go back up a little bit more, John, and rotate very slowly. I think you've got it right there.
Yeah, it bucks out every time I do that. That's the thing. It's going to be faster if I just do the Rosen glide.
No, and that's been looked at pretty well. So we got a lot of data from both Rival and Matrix about stroke risk, and it's no more. I mean, yeah, you could do stupid things, right? But as long as you're careful. If you have a wire that's gone up the carotids that you're not aware of, or up the vertebral, the left vertebral, that would not be good. So the danger of doing it by feel and not by fluoro is you could go north and not be aware of it. There we go. So he's kind of got a horizontal arch there. This would be a very difficult case actually to do from the right wrist. You can end up with a Z shape of your catheters and make it a little bit more difficult.
Okay. So in the initial angiogram, the right coronary was basically a totally occluded vessel. The left is almost subtotal. The LAD sort of had some, moderate to severe disease in it, but enough, obviously, they felt warranted a bypass operation. Now, in terms of torquing the catheter, I still start doing what you normally do from the groin, but sometimes that's wrong, and sometimes you need to find out that you need to torque the other way. It sort of depends on how the angles sort of torque off of the catheter there. Let's see, am I in the coronary or not? Nope.
So another advantage of the left wrist is that your catheter manipulation
There's
is
that.
just the same as it would be from the groin.
Okay.
When you go from the right wrist, it's
Over to an
opposite.
RAO.
But you need to know both. There are patients that you're going to do from the right wrist, there are patients you're going to do from the left wrist. So.
Stay on that just for the CTO purposes. Okay. Come to straight AP. Go to 15 LAO if you would.
At least the surgeons were nice enough to mark the graphs.
That was
for you.
kind, yeah.
Yeah.
The question is, will I need a multi to get into this or not?
So a catheter that works really well for doing the internal mammary graft is a 4 French Cordis Lima catheter, Lima diagnostic. It's got a really nice sharp bend on it, and it really likes to go into the Lima. We like that a lot better than the standard one, which has a fairly shallow angle, the standard Limas.
Find this graft here.
It's not uncommon for grafts, and he's going to be able to do it fine with this catheter. But a left coronary bypass is really common.
Yeah,
It's
popped
a
out.
little bit difficult from the left to get over to the anterolateral aorta.
There, that's probably in.
That's working pretty good.
Okay.
That looks nice,
Graph
John.
looks pretty good.
That's his circumflex graft.
Go to RAO. I'm sure it's still in the catheter. Yeah. Okay. Through the RAO.
The other negative about the wrist is you really can't get true lateral views. It does limit what you do with lateral.
You can if you shoot through the arm. You just got to be comfortable with that. Mauricio and I were taught to use a 90-degree lateral. He'll remember that.
Oh, really?
Yeah. Okay, so let's do the following. Let's change out for a IMA, or excuse me, a multi-purpose, and see if we can get at the that other graft. I don't think that this is going to get in there.
So all our catheter exchanges we'll do over the Rosenwire. He's
Yeah.
already got a Rosenwire.
I'm just not seeing. I don't. Okay, good. All right.
So I typically, when I'm doing graft cases, I typically will look at the lima first. So I got the wire, it's up in the subclavian area. I just go ahead and stop there, and I go ahead and shoot the lima, then exchange out and go down. And
Yeah, you're right. We probably could have just looked at the IMA there before I went down there. I'm kind of regretting that given the tortuosity, but. So.
the cordis for French. Yeah, it does. It has a lot steeper angle on it, a little more of a hook. And again, if you have trouble getting into limas from the groin on occasion, doing it from the wrist is really good.
Okay. So again, what we're doing here is we're not flooring while we're putting the catheter out. We're just hand over handing it because we know it's sitting in the tip of in the base of the aorta there. As long as it's sitting there, okay. Now the other thing was we gave heparin. We gave 5,000 units of heparin. And we traditionally have done that. We'll talk about the data that supports doing that for the radial approach. I don't know if Mauricio brought that up in the overview or not, but we can sort of talk about that later. That's a really important aspect of reducing radial occlusion. Huh? Multi-purpose, yeah.
So again, if you're changing out blindly, which was what we do usually, and they start having to run a PVCs, then your wire is flipped across the valve. So that's just pull it back.
And there, okay, did I go into the ventricle?
Yes, you did.
Yeah, I did. I want to measure that gradient, so let's.
So there's never a bad move. It's just
Yeah.
it's an opportunity.
Yeah.
So John, so we have lots of aortic stenosis cases. So what's the catheter of choice that you use to cross the valve?
To cross the valve, typically I start with the Junkins 4 still.
Like you learned in fellowship.
Right, and then it depends. I'll change out based on where I think the jet is, and do I think I'm getting perpendicular with the jet? This is the thing that.
So one catheter that's worked very well for us is AR1.
Is that right?
So one actually was a discovery of one of our fellows. We're just pulling our hair trying to cross the valve, and he brought an AR1. When I walked out the catheter, and by the time I came back in, he was in. So we adopted that. And also for transaortic cases which have a similar approach, because you're coming from a valve, we use the AR1 to cross the valve. It's worked well. I mean, it's worth trying.
Yeah.
A little shorter arm on it than the AL1.
The AR1 allows you to center much better in the root of the aorta in order to direct the wire and cross. No, we do the brachial vein. I think you have a lecture on right arm on the right heart cath, and it's much better. And I challenge my fellows that they have to do the complete right heart cath with less than 15 seconds of flora.
All right. That's enough of that.
Nice thing about it, the swan wants to go in from a
Okay,
right
so let's
arm.
change out for the JL.
Wants to go into pulmonary artery. It's really pretty good. Or we'll do both from the right arm. The one we're going to do this afternoon is we're going to do both from the right arm. How old is that graph, John?
2007.
Oh. So that right graft was occluded, obviously.
Yeah. That's why I looked at the right there. I mean, the right is a CTO that's potentially doable if necessary. We're not going to do that in preparation for the vascular surgery, but if this becomes if the leg gets repaired and all of a sudden now he's symptomatic, then we've got something to think about. That flush, please. So Mauricio, are you still flushing your sheaths after every exchange?
No.
No? Okay. I've still got the images of Vic Behar yelling at me. Mauricio and I trained in the same program. And
Well, the patient is fully anticoagulated,
Yeah.
so and luckily we, in a significant number of cases, I wouldn't say the majority, but I would say, 50, 60% of the cases, we just do everything with only one catheter.
you got a 15 LAO. Okay, so this is a JL4. We'll see if this will get in the left or not. I think the left's sitting right there.
So there's two ways to look. We generally will do a JL3.5 from the left arm. It just needs a little shorter arm for some people. With aortic valve disease and dilated root, then a 4 may work great. Sometimes the deep breath will help. It's a little bit more of a challenge sometimes to engage, and oftentimes when you put a catheter in, it really is directed toward the superior wall of the left main. That's okay, but it means the first injection you do, you want to inject slowly just to make sure you don't do a jet dissection of the artery. So it's just it's less axial than if you were coming from the leg.
Okay, I just doubt that I'm in the corner right now. Yeah, it's close.
We don't use JL3.5 usually for interventions. We use a XB 3.5, or we'll use a CARI or AL1. Yeah, almost never would use a JL shape for intervention. So we got in it nicely, and the tip is down, which is good.
20 of REO and 20 of caudal. Well, the IMA's open. That's good.
The problem with people who use 4s, it's really, in guys,
spider.
it's really hard to fill the coronaries adequately, and sometimes you don't know whether there's a lesion or whether it's just streaming, or, it's kind of angiography 101.
Okay. Iliocranial.
So again, once he has access, it's exactly what Mauricio said earlier. It's just a standard angiography case. I mean, and the same holds with if we're going to rotablate or whatever we're going to do. It's going to be pretty much the same.
Good.
For diagnostic, it would be a 5 or 6 French.
Okay, so let's change out for the
JL
IMA.
3.5.
The curve, yeah, because the way you come down, especially when you come from the right side,
What's that?
you have
A 5 French IMA would be great, yeah.
area where the curve can form. So you need a shorter secondary curve for the JL. So 3.5 usually fits well. And then same thing for the EBU, and EBU 3.5 usually fits very well.
So you guys use a lot of Sarahs and Jackies? Do you do that?
I use Jackie. I'm sorry. I use the Tiger as my default approach for a diagnostic cath. And the Jackie is a dedicated radial catheter that allows you to engage both the left and the right coronary arteries. If you are starting with your learning curve, I think it's better to use Jackies, what you know how to manipulate. And once you feel very comfortable with that, you can start trying the Jackies or the or the tigers. I found useful the Ikari is a guiding catheter that allows you also engagement of the right and the left. I use Ikari for STEMIs because I don't have to. I save in a catheter exchange. I can shoot the non-culprit first and then go to the culprit with.
Yeah.
Sometimes it won't work. In about 30–40% of the cases, you're not gonna be able to engage both vessels. At least you're gonna engage one.
Okay.
Ikari, it's IKARI, and it's the left one. It's IL, and you want to use a
You go to
3.5.
30 RAO,
The
that'd be
curve
great.
3.5. Shuhei Ikari is a Japanese cardiologist that came up with that shape.
So the only negative with it, it's really a good catheter because it sits down on the cusps versus, an AL1, which sits a little bit too high and comes back. So it really grounds itself. The negative is the catheter material softens. And so it's really good for a fairly uncomplicated case that's going fine. But once it starts to soften up, there's no support at all. And you got to put a guideline or do something else.
All right. Now let's see where we are here.
We'll show you some of those shapes lecture this out, either late, I think it's later this morning. So you see the takeoff, how that goes, that actually the lima is kind of taken off this way and then coming down, and that's why a little bit more of a hook
You're gonna feel warm in your arm there.
ends up being good. So he got right in it, and it's a big graft.
Look at
Wow.
that thing. Wow. Look at the right. Go to the right. Okay. Okay, it's got epicranial.
Well, that's nice looking, John.
Yeah, it's a good looking graft. There. Look at that distal right. It's a tasty CTO. All right. Okay. Pan up there, if you would. Okay, good. So let's have the wire. What I have learned through the years is it's better to take these catheters out with the wires. If even with like the Judkins 4, I've managed to get that you're not sure what you went through in the arm, and so I've always just gotten the habit of taking all the catheters out with the wire, and I've learned that the hard way in a couple of cases.
So again, I think there's difference of opinion. Pigtail, obviously, you're going to take out over wire, curved. An R4, I would not necessarily do that. I mean, I think if you get any resistance, it's a different story.
Yeah, I thought that once too, Jeff, and then I got caught up in a radial loop that I didn't know about.
So really, as you were pulling the catheter back?
It jammed, and there's all sorts of pain in the elbow and everything.
Wow.
Yeah. Okay, so we're all done here. I don't think anybody feels like there's anything they really want to do. Things look good. We're going to get this thing out of your wrist here in a moment here, okay? All right, good. So I'll show you how kind of that we have lately been using the TR band sort of as our standard go-through here for closure of the device. And we sort of break open this 3M thing here, and we're going to lay his arm down by the side, and we'll show you that. Do we have a pulse ox that's set up in here? Let's do, how hard would it be to do that? Okay, we'll just move it. Let's move it over. Can we bring the pulse ox up on the screen? We'll just show you the Barbeau test just so you can see it. Okay.
Hey, Pete.
Okay. All right. Can you guys see with the cameras now?
Good.
Okay. Good. All right.
Oh, I thought you were back.
So John, when you do the case from the right side, do you use Tegaderm to secure the...
No.
Because our fellows started to use a Tegaderm because the hydrophilic coating, sometimes you are exchanging phosphorus.
Yeah, my partners have done that for whatever reason. I've been resistant to it. Maybe I'm becoming a fuddy-duddy.
But the fellows introduced that. It was not doing it.
I think if you're having to do, you remember how we got trained to do the whole case by yourself?
Yeah.
And if that were the case, I probably would do it because the coating, I agree with you, does make the thing come out. But usually I've got somebody scrubbed in that's sort of holding the wire and everything, and
We just got used to it, and now the techs like
Okay.
it, the fellows like it, so,
So it's become
I was
a
the last
standard.
one to like it,
Yeah.
but I use it.
I do it on the right for the right wrist
Yeah.
because again, it sticks it down. With the this left technique, that sheath is there.
It's there.
You don't
yeah.
worry about that.
So what we're going to do is we're going to pull the sheath back a couple centimeters here, and then there's a dot on the TR band. I don't know if you can see that, but it's a green dot here. You can see it over that. That's supposed to be about 2 millimeters in front of where the arteriotomy site is, and the reason is that you come in at an angle where the arterioaxial puncture site is probably 1 millimeter or 2 proximal to where the skin neck is, and so that's why you want to sort of set up that way. And you want the hub out of the way of the TR band, really is what you want. So what we're going to do is basically put this on, not real tight, but just snug, so that it's not going to move around. Okay, and then there's a bladder inside here that's an air bladder, basically. And get that up there where we want it. Okay. And then Laura's going to sort of, I think it works easier if it's a two-person operation. So she's going to put 13 cc's of air in the band. Okay, and then I'm going to pull the sheath. And now the patent hemostasis, this is sort of the poor man's version of doing patent hemostasis. We're going to pull back on the air out of the sheath, out of the TR band until we see bleeding. Keep going. There it is. Now you can see the pulsing going on there. So we're going to put 2 cc's back in. So 13 was about right. But typically you want to at least be at the point where you think you've just got control over the bleeding so that there's no, ideally it should be still flow down the artery, but you've got control over it. If you compress too hard, we've learned that that's sort of a bad thing. And over the thumb. Yeah, thanks, yeah. Yeah, I know, but for the test we need to do that. So I don't know if we can bring up the pulse ox on the, okay. Can you put the waveform up, Diane? Yeah, okay, great. Oh, there it is. Okay, perfect. So now you see the waveform there. So what you're going to basically do is if we compress both the arteries, you're going to see it go flat, okay? Now, if I want to make sure there's still patent hemostasis here, I'm going to let it up and see if it'll still start tracking. There's some cyclical component to it there. There's really not, there's a little bit of a waveform there, but not a lot. There it goes. There it goes. So I'm holding pressure over the ulnar right now, and there's still flow down the radial, which is good. That's what we want to see. Okay? Very good.
Thank you, John.
I think that's it. All right.
We'll see you up here in a few minutes.
Okay, we'll see you in a little bit.